this is the magic part of it, where we all get to talk and ask questions. So thank you again for joining us. And before I introduce our great lineup of panelists, I thought I would give a little bit of background on why we made this film. Medicating Normal began as a personal quest to help one human being in distress, and it became a mission to tell an untold story. A highly functioning young family member of mine had recently graduated from Harvard as a stellar athlete scholar. In her early 20s, she began exhibiting symptoms that were soon diagnosed by the best doctors as a serious mental illness that would require medication for life. We were told that she had a chemical imbalance and that if she took her medication, it would keep her out of the hospital. 10 years later, she was on 10 meds daily, and she was on disability and unable to hold down a job as she watched her classmates rise to the top of their fields. Every day she'd call to ask, is everything going to be okay? To which I always assured her, of course it is. Everything is going to be okay. But her persistent worrying puzzled me. I just couldn't figure out why it was so persistent. And I realized somehow that it was not her material needs that she was worried about. It was her agency, her ability to realize her full potential as a human being. And her dream had been to become a great writer. And at this point in time, it did not seem that that would ever happen. I knew that before telling her that everything was going to be okay one more time, that I needed to learn more about the drugs she was taking. So I joined forces with my co-producer, co-director, Wendy, who's on the panel tonight. And eventually we built an awesome team of fellow filmmakers. And we like to think back on the beginning of our research, and we often say it was like going down a rabbit hole. One of the first books we read of many was Robert Whitaker's Anatomy of an Epidemic, meticulously researched. This book for us brought to light published and unpublished studies about psychiatric medication, its safety, its efficacy. We were blown away by what we were learning. We'd never heard it before. And we then interviewed hundreds of patients across the US who responded to ads placed in online support groups for benzo withdrawal and antidepressant withdrawal. We interviewed on the phone first and later in person. And what we heard really confirmed the phenomenon that Bob had outlined in his work, which really ran counter to the prevailing narrative about mental illness that my family had originally run into so many years ago. And the counter narrative, as you'll begin to suspect from the film itself, having just seen it, it was not only are we overprescribing psychiatric medication, and most people agree about that, we are harming patients on a large scale. In 2015, when Wendy and I began researching, nowhere in the mainstream media could we find any substantive discussion about this incomplete reality. We could not fully deny the mainstream message that psychiatric drugs could help, because for some they do not harm, and for others they can help in extreme situations or limited time periods. But to leave out the story of potential harm corroborated by so many suffering Americans confounded us. And so raising awareness about this omission became our mission, and Wendy and I knew that we had to make this film. And now I would like to thank and introduce tonight's panelists. And then they'll briefly introduce themselves, but I just want to go through a huge thank you to Wendy, co-producer, co-director, and executive producer of Medicating Normal; Angela Peacock, MSW, military veteran, mental health advocate, and subject of the film; David Cope, US Naval Academy and MIT graduate, former naval officer, retired naval engineer, and subject of the film. And finally, we are very excited to announce that Dr. Tom Perry as a guest panelist. Dr. Perry is an internist, a clinical pharmacologist, and associate professor at the University of British Columbia. He is co-chair of Therapeutic Initiatives Education Working Group and editor of the Therapeutics Letter. I'd like each panelist to say a little bit about yourselves and or share thoughts on the film or provide an update on about yourself since the film has wrapped. And audience, please, while panelists are introducing themselves, go ahead and start typing your, because you have a part to play in this, start typing your questions in the Q&A box so I can then begin posing these questions to panelists. Thank you, and Wendy, why don't you start?
Well, I'll be really quick. I can't wait to get to the questions. That's always the best part. I'm thrilled to be here.
Angie?
Hi, I'm Angie. I'll make it quick too. You saw my story in the film. I'm almost 5 years off of all medications. I'm too terrified to even take a Tylenol now. I graduated with my master's in social work. It was something I had doctors telling me I would never finish school. I would never be able to handle the stress, and I barely did, but I made it through. And now I help with outreach for the film and do discussions like this one all over the world. This is like our 100th and maybe 10th screening, either virtually or in person. So just like Wendy said, this is my favorite part, to hear from you.
Dave.
So this is my first Zoom conference, everybody. Give me a little slack here and how I present myself. But so I largely, after getting off the psych drugs, I think in 2015 was the last summer of 2015, I largely was able to return to work and function as an engineer, working at a naval shipyard for several years. My relationships with my wife were fully recovered. And got back to a normal existence. And my relationships with my family are basically back to normal. It took a few years to mend some of the harm that was caused during that time in those relationships, but basically back to normal with respect to those. So I think I'll leave it at that and leave it open for questions.
Thank you. And Tom?
Well, I'm the oldest person here. I could leave it
But
at
the
that.
best looking.
I'm a general internist. I've been a doctor for 42 years now. And this is the second time I watched this film. I just think it's a remarkable film. I was making notes this time, and some of the wisdom from not only the affected people, the patients, but also the consultants interviewed in the film, they're remarkable. It's definitely worth watching at least twice, maybe 3 times or more. I'm very glad you invited me.
Thank you. Well, we'll invite you again. So we're going to start with you because we thought that you would be able to kick it off and set the tone. And our first question is, how do we know psychiatric drugs work, and for whom do they work, and who they harm? How does one know that?
Oh my. Well, my understanding is that if you go way back to the 1950s, and Robert Whitaker's book discusses this a lot, and there are a number of other good books that do, these drugs were discovered by accident. And in France, for example, the major tranquilizers, chlorpromazine was the first. The neurologist in France who investigated them observed what they did to animals, and then they observed very closely what they did to people. And they came up with the name neuroleptic, which referred in some way to tranquilizing people and making them immobilizing people. And then the first antidepressants came up from Switzerland by accident also. And it was claimed that some patients walked out of sanatoria. People who'd been depressed profoundly for years were able to leave. I don't know if that was true or not. Maybe they got better on their own. But what you can say is at that time, the psychiatrists promoting drugs believed that there was a major change in the ability of the person to function on a global level. It was like night and day. Nowadays, drugs are simply tested for what you could call proxy or surrogate outcomes, some kind of a score. And if you think, watching this the first and the second time, I thought with horror at some of the antipsychotic drugs given to people who are not psychotic. My God, you know, if you looked at the clinical trials that were used to get approval or sometimes not get approval, what you'd see is that they make people sleepy. And on a depression rating scale, if you have trouble sleeping, then something that makes you sleepier will look like it's better. But it has nothing to do with the overall global function. So that's a big problem. The way we test for drugs now is pretty much, as Robert Whitaker and others said, and Peter Gotcha, so corrupted that it has almost nothing to do with what Angie or Dave or the other three people in the movie would have hoped to achieve.
Do any of the comments, other panelists have comments on what Tom has just said?
Well, it's reminding me of last week. I read 2 chapters, one by Joanna Moncrief and one by Sandy Steingard. And it was about thinking about drugs instead of disease-centered way, the drug-centered way. So like, if you take a stimulant and it works, people will say, oh, see, you have ADHD because the stimulant worked. But if you give everyone a benzo, everyone gets sleepy. So it's the difference between a drug effect and a disease effect. So it really made me think about this in a different way, where people are going to take psychiatric drugs, right? But maybe it's not so much they're treating something, like going to this place of a disease, that there's either stimulants or there's depressants. And that's really the only 2 things you can get. Antidepressants are more stimulating, tranquilizers and antipsychotics are more depressing. It's pretty simple. So I don't know. That's what I just read last week. I'm still cultivating that information, but what do you think about that, Tom? Maybe too simplistic.
Yeah, I agree. I mean, my late father was a pediatrician turned neurochemist. And I grew up in the 1960s when he believed that perhaps if he worked hard enough, he could discover the cause of schizophrenia. Or as he would have said, these schizophrenias, he saw even schizophrenia as a syndrome as probably multiple conditions. And I think by the time he died in 1991, I don't think he any longer believed anyone was going to find a simple explanation for these. And I certainly don't. You know, 30 years after my dad's death, I don't expect to know by the time I die, which I hope will be quite a while from now. I don't expect to know what causes major mental illness. I think, you know, in your story, Angie, it's so transparently obvious that it was war that caused your problems. And in Dave's situation, it's excessive stress and the lack of a humane response. Is very similar what Dave experienced to what I did as a trainee in medical school or internship or internal medicine residency, excessive stress. I was lucky enough that it never broke me, although I quit at one point and got out of it. And I, you know, it's so poignant to think of Dave's story and think, what if one of his professors had said, you know what, you're really good. We don't want to lose you. We want you to go take a sailing holiday. What would they have lost?
Yeah, I mean, looking back, that's the reality of the situation was, had I just taken some time off, regrouped, you know, taken a few weeks to clear my head, I would have never had to walk into the psychiatrist's office to begin with, because my sleep probably would have gotten back to normal. I would have been able to relieve the stress, kind of the acute stress I was going through at the time. And, you know, the likelihood that I would have gone down the road I had would have been a lot less. Now, I was in a position at the time that I could not take time off because I was being paid by the Navy to be in that program. So if I dropped out, I would have had to leave MIT. So there was a combination of pressures that kept me, you know, required me to stay in. But, you know, getting back to the original question, you know, for me personally, having come full circle through all this, you know, my conclusion, and it's, you know, I would say non-scientific, is that some of these drugs have some uses some of the time. you know, benzodiazepines. I've had surgeries before, and before surgery, they typically give you a benzo before the anesthesia to help calm your nerves. You know, once off, I did it, and it helped me get through that, you know, the anxiety of going into surgery. But the other side of that is once you start prescribing these continuously over long durations of time, you know, you're totally changing the outcome of the patient and the way, you know, and causing all kinds of issues down the road. I can't tell you, when I was recovering, you know, my boss's wife went through basically the same exact thing I was going through, and I was coaching her trying to get her out of the psych ward because she was trying to recover from being on a benzodiazepine. And you know, so the way I sum it up when I talk to people is I'm not an absolutist one way or the other. I just think some of these drugs have some uses some of the time, and people just need to be way more informed about what they're getting into and what the potential outcomes are when they stay on them for long durations. And as well as that is the understanding that when you start combining the drugs, there is little to no information or research into what's going to happen when you start combining the drugs. So, you know, I'd say that's how I would sum up my response to that question.
Oh, as a clinical pharmacologist, Tom, if a patient, like anyone in our film, presents to you saying that they feel impaired or not good, what would you, at least in these situations, what would you have wanted to know to assess the situation? For instance, how can a clinician or even a patient know what's an adverse drug effect and what is not?
Oh, well,
yeah.
I think the first step is a very simple, logical approach, which is to get all the medications out ideally right on the table in front of you. You can even do it by Zoom. I did it about a month ago with one of my patients in his own home, and he put them out on the desk in front of him, and it worked just as well as in the office. And then record the doses and start with the very simple questions. What is supposed to be the purpose for this one? If a person can't answer that question, it should probably be moved off to the side and headed towards the wastebasket. That's a very simple screening question. And then go through that list and then ask, you know, do you have any clear opinion as to whether it's helping you? And I think the way you have portrayed the stories of the 5 people in this movie, the only person who might have said yes to that was Shalimar in New York City. At least at first she might have said, yes, it's helping me. The other people, I didn't hear that from any of them. And then the next is what if any adverse effects or side effects do you feel? And do you know what they would be? This is the key one where very few people actually seem to know. Typically people don't read the package insert. What the pharmacist who treated Shalimar was saying shows a very erudite, well-informed pharmacist, but he's right. Nobody reads the package insert. However, anybody can answer it with Wikipedia. I found Wikipedia remarkably accurate. I've yet to find a problem with a drug with Wikipedia. And then another useful tool is the drug monograph in the United States. That's called the drug label. I got curious about, I think it was Bree's story of the Vyvanse and Dave's attempt to help her get off using that beautiful logarithmic curve. And I looked it up in the background as the movie was finishing and realized, wow, the Canadian product monograph, all I have to do is type in Vyvanse monograph or the generic name lisdexamphetamine. I had forgotten that it's a prodrug of dexamphetamine. Once you get it into your bloodstream, it's converted to dextroamphetamine. It's the same thing. It's not more potent the way the psychiatrist told Bree. That's complete bullshit, if you forgive the expression. And you can rapidly learn about it, and you can equally rapidly learn that the maximum recommended dose is 60 milligrams. And I think Bree at one point mentioned she was on 120. So somebody gave her a dose much higher than approved in Canada, and I suspect it's the same in the US. Those are a few things I ask. I also think it's very important to look at the person. You know, we are not, I know this for a fact, we are not training our young doctors, our pharmacists, our nurse practitioners, our physician assistants, probably not our social workers, with all respect, Angela, although it would be very good if we did train them, to look for the adverse effects. Like the person who converts to how Dave looked in some scenes of the movie, even when he wasn't on drugs, he had a very limited facial expression. I managed to provoke him earlier this evening, and I just did again into a smile there, which shows to me that he's not Parkinsonized. But if he'd been on an antipsychotic drug, I wouldn't have been able to do that. And that kind of skill is not, we're not teaching to our health professionals. They need to know that.
I just want, Angie, yeah, add what you were going to say.
I was just going to say something that, to piggyback off what Tom said. I think, well, I was one of those people 6 years ago that I thought the drugs were helping me and that I could not live without them. And I had such bad anxiety, I couldn't cope without them, but I didn't know that my symptoms were either being worsened or keeping the trauma very present. So if you would have asked me those questions while I was taking those drugs, I say this often, like when I was on 17 at the same time, it takes away the ability for you to even know that there's something wrong with that. Like you can't even question, why am I taking all, you know what I'm saying? So, and I would not have known the difference between me, the mental illness, or the drug. Like I had no clue. I thought it was all just one thing. So, I mean, that just shows how far, you know, and a lot of times people say like, well, your trauma came from, like, kind of like how you said that it came from a clear reason. And I don't know, I think because I appear pretty well now, they don't think that I was severe. And I was extremely severe. Like I didn't leave my house for 4 years. I couldn't talk to people. I mostly just sat around the house. I didn't shower. I barely went to the grocery store, and it would be at midnight to snatch something and leave. I mean, I was really in a bad place. And now that looking back, it's like it was the polypharmacy that was doing it.
I want to just lead into one of our audience members' questions, but it had that, I liked what you said about look your patient in the eye, Tom, because so many of the stories that Wendy and I heard, patients felt they were not being looked at, they were not being listened to, there wasn't time to even do that. And it leads to this question that I want to pose everybody. I believe that medications are a shortcut to talk therapy. What in heaven's name are we going to do about creating better access to psychiatrists and psychologists who are willing to invest in their patients with time, and insurers who are willing to pay for this? Does anyone want to comment on that? The experience of going to a doctor.
I mean, I'll just say I agree with that perspective that early on, I would go in, you know, I'd sit down, I'd talk to him for 30 minutes, but then as soon as I was on the drugs, that became like a 15 minutes, and that became like, then you know, over time became a 10-minute check-in, and then a 5-minute check-in. And, you know, I quickly realized fairly early on in my whole experience that, you know, I was just being put aside, and, you know, the drug appeared to be the only solution that was presented, you know, to me at the time from the professional that I was supposedly seeking help from. So, I mean, to how to solve that, given our current, at least in the U.S., the current insurance market and the way they give incentives for them, yeah, I don't have any solutions for that, but it is definitely a problem that is rampant. I mean, and the way, listening to my wife and how her appointments would go, you know, she's been getting off Vyvanse over the last several years. You know, it's about as close to a drug addict, a legal drug addict you can get. Go in, you know, are you still breathing? Yes. Okay, here's your next prescription. See you in a month, you know, and it's really pathetic. It's just pathetic. Doesn't even gather all my thoughts on it, but that's what I would say.
Angie, this is for you. Let's see, how are we all going to tackle this problem among non-medical professionals? As a nurse practitioner, half of my challenges are patients coming in from counselors, social workers, psychotherapists, and other people who they have trusting relationships with, and requesting drugs at the advice of their counselors who have told them that they need these drugs.
That's a big question, but
Yeah.
I mean, I can tell you just through going through social work school, I would approximate like 60 to 75% of my fellow students were taking some form of antidepressant or benzo or sleeping aid. So it's prevalent, especially in the helping professions. I mean, I do think we are more, I don't know the word, indoctrinated into thinking this is what works. You know, this is the narrative that you need help, you go to a professional, you get medicine, that's what you do. So therapists are definitely complicit in that system in a lot of ways. There is a really good piece of, it's recent, we just did a screening with the University of Roehampton in the UK. So there's Dr. Ann Guy and Dr. Rosemary Risk, and they did a pretty extensive pamphlet for psychologists to talk about psychiatric drugs with their clients. And it's just simple questions like, what meaning does it have for you to take a psychiatric drug? What does it mean for you to, do you ever want to come off of them? You know, like these little seeded questions, because right now, like at least in the US, in the social work program that I went to, and was like the top 1 or 2 program, depending on the year in the US, we're not taught anything about this. I took a psychopharmacology class just so I could get credit for what I already know, but I had to learn the hard way. But we're told to like stay out of that. Like, you're not supposed to talk about medicine. That's the doctor's problem. You stay out of it. You do everything else, you know? So I think that we need, as non-medical professionals, we need to get in on that conversation, because in social work, you're supposed to look at context. Like, what context is the person living in? What other things are happening in their life? Are they dealing with poverty or oppression or racial injustice, all those things? Well, medication is part of that. You can't just say like, I want to help this person except for that part. So I don't know what way we can each get involved in that, but we need to. Wendy, yeah.
I think that this question also relates to the pharmaceutical companies have sort of created 2 connected narratives that everybody believes to some degree, which is, one is that this drug that you're going to get, I mean, you go in with a problem and there's an idea that, well, this drug will solve it. It will keep you functioning, or that you have an illness, a chemical imbalance, and this drug is therapeutic in the sense that it will correct that. And one of the things we tried to do in the film was just to kind of deconstruct that narrative and, show that it's really inaccurate. And then that leads to a different way of approaching the drugs. Like Angie was talking about before, that, yeah, the drugs may change your brain and change how you feel, and that may or may not be helpful. And in the long run, that may or may not lead to a lot of other issues. And if you want to think about it that way, go ahead. But don't think that it's either a magic bullet or correcting some chemical imbalance.
Wait, Tom wanted to say.
Oh,
yeah.
Tom.
Yeah, I'm not sure if I'm answering this question or something else, but one of the questions, a good question I think you asked, was from someone I know quite well about how does one reduce the flood of recommendations for drug therapy from people one might hope would know better or know differently. I mean, I'm not anti-drug any more than Angie is. I wrote down from the film something where she said, I'm not anti-drug, I'm pro-informed consent, or something to that effect.
Yeah.
And I, like Dave, I think there are situations where drugs are quite helpful to people with mental illness, and I'd prescribe them. I don't think I've yet prescribed amphetamine to anyone, because I was taught in the 1970s that they were addictive drugs and it was a bad idea. But I've prescribed antipsychotic drugs to people who were frankly psychotic and dangerous to themselves or to others. And it wasn't a great solution, but it was at times better than nothing. But one of the sad things to me, and I noticed there's some people in the audience who I think are closer to my generation than others. A sad thing is, I was taught in the 1970s that as a doctor, you better get used to the idea you're not that special. You're no longer going to be dominant over nurses or social workers or pharmacists or anyone else. And I think I believed that. I thought you know, we should develop a more respectful relationship and listen to each other. And I think things have gotten worse since then. I used to do a lot of consulting on a major psychiatric ward, and I would see people who'd been in the hospital for months, not getting any better, accumulating more and more drugs onto their list, and wandering around the glass nursing station like fish in an aquarium, very slowly and obviously Parkinsonized. And when I asked the experienced nurses, you know, do you see what I'm seeing? Do you say anything to the psychiatrists who are prescribing this? Well, no, of course we see it, but we can't say anything. They don't listen to us. I'm not kidding you about that, but I can recall once or twice seeing a social worker's note in a medical chart calling attention to what was happening. Once definitely from a counselor, but very few such examples. And I think somehow part of the solution is to build more respectful assertiveness into the other professions, but will call the bluff of the doctors. You know, anyone who's prescribing drugs that are, you know, more significant than Tylenol, acetaminophen, drugs that have serious effects on people, has the responsibility to know about them, and yet very few people do. Even what Andrew was referring to, the distress or anxiety when she started taking the drugs. To me, in the 1970s, that even as a medical student, that would have meant what they called it, they used a Greek word, akathisia, internal restlessness, inability to sit still, getting up and down from a chair, like one could observe on a schizophrenia hospital ward, people moving around aimlessly and then getting up and moving quickly and sitting down again. That was known in the 1950s to be one of the built-in adverse effects of the antipsychotic drugs. But I don't think the modern doctor or nurse or any other professional understands that. And how does that happen? That's a disgrace to our training institutions, because often the people who are in charge of the training don't know any of this themselves. So that requires a more extensive revolution of the kind that you're starting with a film like this.
In fact, now I just saw an advertisement for akathisia as if it was a disease that just popped up and there was no reference whatsoever to its cause. And now there's a drug that treats akathisia. And anyway, well, I want to jump to something, Tom, well, that we know that you know something about. We recently had someone from the FDA Consumer Panel Board on one of our panels, and they defined and started talking about the term evergreening, which relates slightly to what we're talking about. Can you, with the practice of remarketing drugs with new names, what are some other examples or examples of evergreening, and can you talk about that?
Sure, yeah, I'll give you one in the film and one from a questioner. I've been keeping an eye on the questions as well. The one in the film is mentioned very rapidly at the scene at the warfighter advance camp. It's the chap who has the most of all the drugs. And I think Angie points out in the film, my God, look at this. He's on 2 antipsychotics and the injectable and 3 antidepressants. The injectable is mentioned very quickly, and it's referred to as Invega, and my monthly Invega.
Yeah.
Now that's the brand name in the United States for a generic name, paliperidone, Paliperidone. You look that up in Wikipedia or look up the US drug label or the Canadian monograph or whatever it is called in another country. You'll see that paliperidone is the active metabolite of risperidone, brand name Risperdal. So anybody who takes Risperdal, makes paliperidone in their liver. And yet it was marketed as a new drug. So whoever prescribed that to Angie's colleague in the warfighters
advance.
Probably was conned into thinking it's somehow different from risperidone. And it might be, in theory it might. I'm not aware that there's any known advantage to it. Another one that came up in the question is someone who said she's having a great deal of difficulty getting off of Prestige. Prestige, if you think about it, it probably will conjure, if you were in a focus group and asked, what do you think of this name? When I've tried that experiment with my medical students, I say, well, boutique, something like a boutique, like a special, or pristine, like pristine nature. It's not accident, it's called Prestige branded, but that is desmethylvenlafaxine, which is the breakdown product of venlafaxine, Effexor. So anyone who's taken Effexor also, it wouldn't surprise me if the questioner was on Effexor first, and if that didn't work satisfactory, is now being put on Prestige as supposedly better, even though she already had a lot of Prestige in her blood and in her brain when she was taking Effexor. So it's a technique that the companies do when the patent expires. There's innumerable examples in psychiatry, like escitalopram, Cipralex or Lexapro versus citalopram, where they extend the patent by making a minor modification or taking two halves of a drug that has a left and a right hand form, and they take the left hand, which is escitalopram versus citalopram. Or you
And
take
then they can get a whole new patent,
Yeah, and the Vyvanse is another example of that. You stick an amino acid onto the dextroamphetamine, and you con even people like me into thinking, oh, it must be a little bit different. It's not. It's just broken down into dextroamphetamine in the bloodstream. It's a good test for a quality of a psychiatrist or prescriber, any doctor, nurse practitioner, PA. If they're giving you this nonsense, and you can find it out by looking at Wikipedia or reading the drug label, question them a little bit more carefully the next time you meet them.
Yeah.
I'll just add a little bit to that. It's not necessarily about evergreening, but just the history. It's kind of like this generational knowledge of what these drugs can do and the adverse and the harm they can cause. I mean, benzos is probably one of the worst offenders in this respect. When I first started taking benzo, I had no idea really how long they had been around, what it was. But after my whole experience, I was doing research, and you can go back to the 70s when the U.S. Congress was holding hearings on the dangers of Valium. There was the Senate Science Committee or something, Select Committee on Science, and they had people testifying about how Valium had destroyed their lives and how it could be dependency forming. And that's what I really woke up to realize, that there's just a lot of generational information that in the medical community, it just gets lost in the mix. And all of a sudden now, they're throwing out benzos left and right, when 30, 40 years ago, it's fairly well known that they are they can cause dependency and severe adverse, withdrawals. And it was just real shocking to me when I learned that, that basically, there's generations of doctors who aren't benefiting from past experience and knowledge gained on these pharmaceuticals that have been around for 40, 50 plus years.
Angie, here's a question for you. Someone writes, I think it's really important to deal with the issue of drugs in the military. The diagnosis of PTSD was supposed to be a benefit, saying you're not crazy, you're not weak, you have a chemical imbalance. It was supposed to remove stigma. Do you think a diagnosis is destigmatizing? And if so, how do you separate the diagnosis from the treatment?
Yeah, that's something I've definitely been wrestling with. That I guess, like, before the film, before they found me, I was very much like a poster girl for PTSD. Like, I suffered through something hard. I live with PTSD. I had a service dog. And the suffering is real. So I don't ever want to say that, I still have, symptoms, whatever, of post-traumatic stress. Now I have medical trauma on top of it, because of all this stuff that's happened to me. But yes, the history of the post-traumatic stress diagnosis was that Vietnam vets fought for it to get recognized in Congress so that they could get disability benefits for it. I feel like that's backfired a little bit, because now, we have a whole generation of veterans that want to be validated for what they saw. It's almost like a badge of honor to say, like, I saw something really bad, it affected me, It was horrible, but it's like almost disempowering. The way that our system is set up, that you get paid disability payments to stay ill. Does that make sense? It's like, I don't know, it's backwards, but at the same time, there's a paradox because I am definitely suffering, right? I'm definitely impaired. I wish I wasn't. I wish I could just go back to work and forget all of this ever happened. But it's just not the way it goes, especially with the medical trauma that I'm still dealing with. It's like, how do we repair that? To say that, yes, you had something hard. Yes, you need assistance when you come home, but let's not make it a chronic mental illness, severe, where you can't ever function or have a relationship or go back to school or be a productive member of society again. I don't know the answer to that. And drugging it is obviously not working because the suicide rate of veterans is like 20 to 22 veterans a day. Before I pass to the next thing though, something really important happened yesterday. There's a piece of legislation. It was called HR 100. It was originally written by Senator McCain from Arizona before he died, called the Veterans Over Medication and Suicide Prevention Act. And it was to go back retrospectively and study all the suicides from the military to find out what therapies were veterans given, what medications were veterans given, to see if there's any correlations between drugs and suicide. It was just signed yesterday. But now it's going to be like the National Academy of Sciences has to study that, and that could take 5 years. And then me not trusting science anymore in this realm, I'm like worried, like, what are they going to find or not find? Because I know when I see all these suicides happening, the first question I ask is, what are these guys taking? Me having lived through it, I know that it made me suicidal more than once. So anyway, it's a big question. I don't know the complete answer.
Tom.
Well, you know, a Canadian perspective, there, it comes back to one question earlier on how could one improve the delivery of mental health and make it less drug focused. From a Canadian perspective or United Kingdom or European, of course, for those of you in the US, a single payer system is the obvious first step because your entire country is so profoundly disabled by having that crazy medical system organization that you have now. If I were a veteran, I think I'd be a little bit more optimistic with the possibility that next week you might elect a president who is sympathetic and empathetic to veterans as opposed to one who despises them. But that hopefully there'll be a chance for some more open, greater openness to reforms in the US next year. But I think the one thing I was thinking of watching the movie and that relates to what Angie just said is that PTSD is one of those diagnoses that seems to be applied to people as if they're hopeless. And I see that a lot in people who get into motor vehicle accidents and get involved in litigation and are then labeled as ruined. Partly because it's part of the legal structure that the plaintiff consultants are being asked to say this person is destroyed so they'll get more money out of a settlement. And the more I've read of that, I've been thinking back, we would never say that to someone who's sick with cancer. It would be just grotesquely unethical to say, you know, you'll never get better, it's hopeless. And we used to say that to people with spinal cord injury, but I think probably sometime in the 1930s or 40s that changed. Used to be said to people with blindness and deafness before people like Helen Keller. And in mental health, the notion that, you know, that you can't get better is just inherently self-fulfilling and very destructive. And to me, that's a place where particularly maybe non-medically trained people like social workers, other mental health workers, can look for the strength of the people. Because when I watched the movie the first time, I thought, wow, there are 5 people in here, plus the parents of the young woman, who are quite heroic and powerful people. And it's kind of the most moving thing about watching the movie is to think, I would really like to know these people. Like, I feel really privileged to be on the panel with Angie and Dave tonight, and I wish the other 3 or 7 people were there too, because, well, these are very strong people who have an enormous amount of of resilience and capacity. How dare anyone portray them as being hopeless? And that's, that's been very important in healthcare in general, that we should look at people's strengths, not just their weaknesses.
And also, before we pass to the next question, the way that I reacted to war is normal. It's not a disease. And that believing that took me down a path. I mean, while you were speaking, Tom, I thought about the first time a therapist asked me, I want you to say 3 good things about yourself. And I literally couldn't, because I was so believing, I lost my career, I lost all these things, and now I'm just a disabled, mentally ill person wandering the streets. That's what I believed about myself, because that's what happens when your life is focused on psychiatry appointments, therapy appointments, getting your BMI taken and your blood pressure and your blood work, because you're on so many drugs, like you become this non-thing,
I love this question here, and it's for Dave and Angie. So Dave, why don't you start? How did you, and I know you have an interesting answer to this, how did you find the best way to describe to your friends and family what you were going through with your withdrawal? This questioner is partway through tapering off Pristique. It's one of the hardest things is feeling like the people around me don't really understand the huge impact that this drug has had, and trying to come off of it. Dave, can you start? Yeah.
I mean, I think the reality is unless they've been on that drug or a similar drug, they're never going to understand the level of suffering. And even when I started reaching out and met people like Angie and people, there's a forum called Thriving Antidepressants. You learn quite quickly that everybody's having kind of their own experience. There's a cluster of symptoms that occur depending on which drugs you've been on and how long you've been on them. But the reality is, your family and friends, the best thing they can do is give you support and understand that it is going to take time to come off them. Our culture, our age is, we expect everything to be, fixed by tomorrow or fixed by next month. If you've been on these drugs for years, or for some people even decades, you got to think of a timeline of years and decades to potentially get off of them, especially when it comes to the benzos and the antidepressants. But to tell your friends and family, the best thing is just give you time. And one of the main things that I suffered with or was put through was my family and everyone around me was trying to push me back into the medical model. I spent time in a psych ward when I was coming off. I don't know if that ever got in the film, but I was pushed to go do ECT and TMS. And in the back of my brain, I'm like, I'm not crazy. I know what's going on. I can feel what's going on. I know where I was prior to taking psych drugs, and I knew what I was experiencing in the moment, in that time. And so, the best thing I can say is understand that they're never going to really understand what you're going through. The best thing they can do, and the best thing you can ask them, is give you time, space, help you with, sticking to a strict taper. Sticking to a strict taper is a lot of work, but that is the key to getting off them in the long term and staying off. But yeah, that's how I would sum it up. I don't know if Angie has anything she wants to.
What he said was perfect. The only thing I would add is that I learned very quickly to be careful who I tell what to, because I was experiencing some extreme states that would be labeled psychosis. I was, I'm trying to not say too much because I'm always aware of that, but like suicidal, and as you saw in the film, like homicidal things. And I had a really dear friend to me that on day 9 of withdrawal, first of all, I didn't even know it was happening until day 6. And like kind of what Tom said, I Googled it. I just Googled benzo withdrawal. And this is me with a bachelor's degree in psychology. I didn't know benzo withdrawal was a thing. I had no idea. I thought I took a low dose. I was taking my medication as prescribed. I wasn't craving it. I wasn't buying it on the street. I didn't think I was addicted to it, anything like that. So then I Googled it, and there was all my symptoms on Wikipedia. That's exactly how I figured it out. Oh my God, I'm in benzo withdrawal. That's what this is. So on day 9, I told a friend, you have to take me back to the hospital. I can't, something is seriously wrong with me. Like something broke. I was having these extreme like symptoms that like burning, and it felt like gasoline was inside of my skin, and I wanted to rip my skin off, and I couldn't stop moving, which is akathisia, all these things. She said, Angie, if you go back to the hospital, they're going to put you on more meds. And I was like, oh my God, she's correct. Like, I can't do that. I can't let that happen, you know? Because like Dave, I knew the drug was doing this. The way I was taken off the drug is causing this. I know I'm not crazy. I have no reason to want to kill myself, like all these things. So be careful. I learned to be careful of who I tell what to. So I told those things to people that I could trust, that were not going to put me away, you know? And then the second thing I learned was to find healing buddies that were going through similar things, like Dave. Like when me and Dave talked in the film, there's an emotional, I don't know, like when I saw Dave cry in one of the, you know, clips that they showed me before I met Dave, I was like, oh my God, he's been to the same place as me. Because it's like our mirror neurons know, you know, like Dave saw the hell that I saw. So it was better to stay close to those people. And that also, there's a process when you come off of medications, especially if it's traumatic, probably, where you're really angry at the doctors. That's a stage. Like, I'm going to get those bastards, you know, and I'm going to fight this on Capitol Hill, and I'm going to change all the laws. And then you calm down a little bit, and you're like, okay, well, what can I really do to like change it a little bit, you know? And then you start to change it your own way. So just like there's like steps of grieving, there's steps of like psychiatric drug withdrawal or remaking your life after the mental health system, whatever. There's all these different things that happen, and like, I need to talk about it all the time, and I need to get back at them somehow, you know, like there's these things that you go through. I don't know.
I'll just add one last thing to kind of summarize, kind of basically what Angie was saying, but put a different way, is you got to, during the withdrawal process, you got to control your own narrative. The whole reason I got into the psych system to begin with was because I let someone else control my own narrative and tell me something was wrong with me and that this drug was going to solve all my solutions. So I learned fairly early on, it was when I was in the psych ward, you know, banging my head against the wall, and nobody was listening to me, and everybody was telling me I was crazy, but I knew I was just going through this immense physical, neurological dysfunction. I just, then and there was like, I got to control the narrative. I can't let people who do not understand and cannot physically be inside my head, because it's just not possible, tell me what I'm going to do or what is going on. I knew what was going on with me. I had read about other people going through similar suffering, and I knew my history. And so control your own narrative. Don't let other people put their opinions on you or their assumptions, or, you know, basically is how I would sum it up. And that's how I survived.
So true.
Well, I think also, oh, well, Tom, there's just a related question that comes, and I'll get to you next, that the control your own narrative that Dave is talking about, I think also may in fact apply in a funny way to doctors, young doctors in training, or health practitioners. What can we do moving forward to combat this issue? I am relatively young, and I have a passion for helping people, and I want to pursue an education in medicine, and I'm quite fascinated with psychiatry. Any tips on, and this would be good for you, Tom, any tips on how to navigate the system in light of over-medicalization, especially with so many conflicts of interest in pharmaceutical industry power? What does a young doctor in training or mental health professional do if they are curious? I mean, every subject in our film and all the doctors in our film self-educated. They read. That was the one thing our 5 subjects had in common. And would you not, Tom, say that that quest and thirst for really finding out knowledge also applies to residents and people in training?
Oh yeah, and you know, anyone who's been a good medical student or known one, or a good social worker trainee or nurse or anyone else, knows that most, or at least many, are quite idealistic, not all, and that those who are idealistic want to do the best possible job usually. And there are always constraints on them. Right now during COVID, it must be absolutely crazy constrained, but you can surmount the constraints in some ways, but if you're willing to work at it. So one is, to look very carefully at somebody's record. If we had access to the hospital records of Angie or Dave or Rebecca, the young woman, we would have been able to go back and reconstruct the story of what happened to them. I've certainly done that, including with psychiatric patients. And one does that in internal medicine as well, in hospitalized patients with medical illnesses. They're not doing well. If you're smart, you go back and try to figure out what went wrong. And I think that is inevitably a learning process. And if you're a young person, as you encounter the barriers, you get scolded by somebody saying you're out of line. This is not your role.
Mm-hmm.
Sometimes one has to step back. Other times you learn, no, I'm right about this. This person's been getting worse. And, I had a trainee, I was using her quotation just yesterday in a different teaching session. A student who did an elective with me in fourth year medicine 3 years ago, not long after, was working on a psychiatry service. And she sent me an email saying, I just want to let you know I learned something from you. This woman is on multiple drugs and is doped out and somnolent. And when I asked, do you think it could be too many medicines? The whole team of psychiatrists laughed at me as a student. And then they wanted to add lithium and an amphetamine or something to try and wake up the person. I realized from that, oh yeah, I'd forgotten about that wonderful email. All right, she wasn't able to do much at that moment, although you never know what impact she may have had, but she consolidated her own learning by that experience. And it proves to me she was highly ethical, and she will carry on asking good questions during her career. So it really helps also if you have a good mentor, but one never knows who the mentor is. It might have been Angie as a student in her class. It might have been Angie tonight in the movie saying, I'm not allowed to talk about this at my own Washington University social work school. That's why I had to come to UCLA where I was welcome. Think about that, those of us who are faculty. Why wasn't Angie teaching in her own university? Why isn't she now? Maybe she is. We can hope so.
You're muted,
muted,
Lynn.
Lynn.
Lynn, you're muted.
Tom, this question is for you. One of the hard things with all of this is that there's not good research to determine the true numbers of people who are harmed versus hurt. As Dave said, sometimes for some people, the only way to really assess these drugs is to get better data. Any recommendations for how studies can be performed to generate this information, or is it even possible?
Well, I'm glad you asked that because I spotted that question too.
Yes.
And it turns out there is some research like that, and we could get more if we worked for it. I'll give you two examples. Just 2 days ago, I think it was New England Journal of Medicine's Journal Watch alerted me to a new analysis of dose response for SSRI antidepressants. A large systematic review and meta-analysis published. Actually, anyone who's interested, you can look it up. Open access. You don't need to go through a library at Acta Psychiatrica Scandinavica. ACTA is the first word. Psychiatrica, scanned as in SCAND, Scandinavica. It's in a very recent issue, I think the current issue. And what it shows is that there's basically no dose response above the lowest end of the manufacturer's recommended dose for SSRIs as a group. Now that's at least the second or third such analysis. So those doctors who say, well, you haven't got better, I think, it might be working a bit, but we should increase the dose, as you're going to need a higher dose. They're not practicing scientifically. It's possible for an individual, a higher dose might work better, but on average it won't. And that's one good example. Another one comes from United Kingdom in Manchester, I think, Northern England, an experiment of adding a second antidepressant in general practice to people who already are taking one. The second one they added was mirtazapine. And they clearly showed there's no benefit of adding a second antidepressant to the first one. I think some in this audience won't be overly surprised by that. But yet it has been absolute dogma in psychiatry for the last 20 years, 30, 40 years, add more. Well, that would be patient-oriented research. Now in the US, you've got the PCORI with the Patient-Centered Outcomes Research Institute, whatever it's called, which is supposed to have a mandate to do research about outcomes that matter to patients. This kind of research should be replicated, and I would be very confidently predict that if unbiased, publicly financed trials were done with adding antipsychotics to antidepressants for depression, the results would be appalling. Having looked at a lot of the ones that are sponsored by the industry, which are absolutely riddled with phoniness. They're just, I have one local colleague who participated in one of those, and a big dilemma for me was, should I report that person to the university for participating in a ghost-ridden study? I asked a colleague in 2012, do you think I should? And he said, absolutely not. They'll take it out on you and nothing will be done. So I haven't quite had the courage to report it locally because I think that's true. But the solution to that is a movement that says it's not okay anymore. You're not allowed in high school to write an essay and have someone else write it, pay them, and hand it in. Angie would have flunked out of Washington University if she'd tried that. But it's okay for doctors to be hired to do that by drug companies.
Thank you for
It's
that.
real.
Yeah. we're coming very near the end. There are questions. Well, there was a question about distribution. Wendy, do you want to handle that one about where we are and how to see the film soon?
Oh, sure. Well, our film is we have to keep it off the internet for the moment because we're doing these virtual screenings. So you can always go to our website and see when the next virtual screening is coming up. You can also contact us if you want to organize a virtual screening. We're always thrilled to do that. In Europe, we're going to be on television shows in at least 3 or 4 countries so far, hoping for more. And then we're hoping to be online in America sometime early next year, or in the spring. We'll be on Amazon, Hulu, platforms like that, the website. So then it will be easier to see the film. Yeah, I think, did I answer everything? And please also go to our website for more information. You can email us there. We'd love to hear from you. And we have a great YouTube channel with, all of the experts in the film. We did about an hour-and-a-half interview with each one of them at least. And there was so much interesting information. So we cut it up into 2 or 3 minute subjects on the YouTube channel, and there's really a lot of great information about side effects, about withdrawal, about pharmaceutical company corruption, really about all the issues that people have been asking about today.
So now, thank you, Wendy. I want each of you to sum up your thoughts, or if you have one final missing nugget that we missed from you. There are other questions, and I apologize that we couldn't get to them, but maybe in your final remarks we'll get something across. Let's see, Dave, do you want to start? Dave, you're muted. Yeah.
I was in the middle of typing an answer. I'll get back to it in a sec. What was your question? Closing remarks?
Yeah, just.
Oh, I don't know. The film, I think Wendy and Lynn did a superb job. It was a great experience to be a part of it. It helped, the whole process of being in the film helped me and get through the nightmare. I mean, for me, one of the ways I describe my experience is just a living nightmare, hell on earth. And being around Wendy and Lynn and meeting Angie, it's one of the, and another adjacent person in this whole process, Laura Delano, learning about her experience really kept me alive, kept me from harming myself and believing that there was a light at the end of the tunnel. And, like I said in the beginning, I was got back to a regular life. It was a new normal, I would say, both emotionally and cognitively. Cognitively. But I'm just glad I could be a part of it. Glad we could spread the knowledge that people like Angie and I have gained on this unfortunate experience. And that's, part of our healing process is being able to share that and keep people from, further harm.
Look, Dave, we salute you and Angie, everyone in our film, as Tom points out. You guys had the courage, which it just does not every day that people have that kind of courage to be able to share what's going on. And I remember so clearly when you called and said, I have to tell you something, and you didn't feel well, and but you guys did it, and thank you. Angie, do you want to? Oh no, I want you to go last. Okay. Tom, closing remarks.
Well, two pearls maybe. Well, I think the only thing that I disagree with, perhaps in the thrust of the film and the discussion tonight, is that these are relatively extreme situations portrayed in this movie. The fact that they're common doesn't make them not extreme. Maybe there are millions or even tens of millions in North America in this situation, but it's still very extreme. But my clinical experience has often been a little more salutary in removing drugs, that not everybody has a horrible withdrawal experience. Mm-hmm. So I don't think one should assume automatically that you've been taking Effexor, for example, venlafaxine, which is a notoriously addictive drug in the sense of breeding physiological tolerance. You've been on it, you can't possibly stop it. No, people have showed that with cigarettes 50, 60 years ago. Some people can stop cold turkey. They may undergo withdrawal. They make up their mind to do it, and they do it, and that's the end. Mm-hmm. So I've created problems at least twice by withdrawing drugs too fast. But for that, there are several hundred people in whom I've stopped them abruptly without a problem. Now, everybody, as your movie says, people should do this under supervision. The other little pearl would be, if I were in maybe Dave's situation, is sort of the closest to my life experience, and I had a wife like him, which I do, but if I were in the same position, knowing what I know now, I think I would ask my wife to video record me. So there would be an image of me and a clear picture before as well as after. And I could then not so much look at it myself, but I could show it to others to say, wait a minute, I wasn't this bad when I went to you. Now look what's happened to me. That's been a teaching technique I've used a lot. I don't usually get to see people before. I see them when they're messed up, record them later. And it's an extremely powerful teaching technique. And it's something that someone like Angie could use in her professional life if she feels she can get consent from the patient. But any patient could give their own consent themselves, especially if you have family or friends around you, to sort of get a pre. And, this has been very powerful in medicine. There's a classic diagnosis in medicine, conditions of the adrenal. Someone who looks morbidly obese and has a face round like a moon. The good doctor asks, do you have any pictures of yourself from a few years ago? And if they look normal before, then they have Cushing's disease, too much adrenal. And it's similarly the opposite. If they look normal before and now are wasting away, one might think of adrenal insufficiency. And the picture would be incredibly valuable. So I think that would be a useful one to explore for someone facing psychiatric drug treatment. I thank you very much for the chance to participate too.
Yeah, thank you. We tried a little bit to do that before and after with our film, but it was hard because we met our subjects when they were in the middle of their journey. But yeah, before and after, very important.
Well, you did somehow. You managed that exactly.
Yeah, we did. We tried. Wendy, do you have a closing thought? Well, I can come back.
Well, I saw a lot of great questions that we weren't able to get to. And I just encourage everybody to email or on the website. We have a lot of resources, actually, resources for withdrawal and books. I see people recommending some books, some of them which were awesome books, and they're probably already on our website. But yeah, it's been really great to see such a well-informed and interesting audience. We used to love when we had the in-person audiences because we would be able to meet everyone, but this audience has had great questions, and I wish I could have met you in person, but maybe someday. I don't know.
And our website is, well, first of all, our email to contact us is, if you have any questions and you really want to get them through, medicatingnormal@gmail.com. And
on the website, yeah.
Yeah, and the website is, yeah, it's on the website. Angie, do you have a final thought?
Yeah. Well, I can echo what Dave said, that my involvement with the film definitely was, I don't know, like it kept me going. I often tell the story about Wendy found me somehow in one of the Facebook groups, and I didn't want to be in the film, and I said no. And then she called me, and I told her a little bit of my story, and then she said, well, I really want to fly out there and talk to you. So she flew out to St. Louis, and she interviewed me, and like we just went for a walk or whatever, and I was like, I really don't want to do this. Like I was thinking the whole time. And then we got in the car, I took her back to her hotel, and when she closed the door, I said, well, shit, I guess I have to do it. But the minute I closed the door, I thought to myself, okay, well, now I can't kill myself, because I don't want the narrative, like Dave said earlier, to be that, oh, she was just this disgruntled vet, this dysfunctional post-traumatic stress, killed her, and oh, that poor thing. I didn't want that to be my story. So I thought, well, I have to stay. I don't want the film to be made and be like, Angie was great, and then she killed herself, So in a way, it did keep me alive, and it does bring me healing to some extent to be able to fight back on these issues. But I can tell you, I'm still profoundly affected from this experience. It feels more traumatic to me. What I've dealt with in the mental health care system and coming off of meds has been more impactful than combat itself, and I don't say that lightly. So and yes, I might be an extreme case, but I meet people like me all the time, and there's just so many of us, and very little help, very little understanding, very few resources or support. So there is a lot of work to be done in all of these areas. And so I just really ask the audience to do one thing to help, like share the film with somebody, or share a YouTube clip, or write up your own story, or provide informed consent, or tell someone to read their FDA label, anything, because it's just like, it's everywhere. And I just feel like we're climbing Mount Kilimanjaro talking about this stuff. So that's my final. Oh, and then I'm always supposed to say, but you guys already said it. Please like us on Facebook, follow us on Twitter, follow us on YouTube. We now have a store with t-shirts if you'd like to support our outreach mission. Share our watch page for other people to watch the film.
Angie, run for senator next time.
No, I'm tired. Thank you. Thank you.
Great. Thank you, everyone, for joining. Come again.
Bye. Good night.
Good night.
Thanks, Tom. Thank
you, Tom.
Good night.
Bye, Dave. Great to see you.
Yeah, good to see you guys too.
Yeah.
Thank you.
Bye, Dave. Thank you.